In this case, the T4 was just marginally on a lower side and TSH value was on a higher side, but not typically in the subclinical range, further on a higher side. So we thought initially of rather we think that probably this is a known patient of hypothyroidism on therapy, so dose increase might be necessary. So we asked for free T4 and clinical details. Free T4 was normal. We did not get the history of any kind of therapy, so probably we think that it is a patient on therapy. So is there again any necessity of further evaluation or antithyroid antibody testing in such cases?
See, antithyroid antibody testing is, if at all one wants to do it, is actually advised between the TSH of 4 and 10 when you want to take a decision about treating. If you look at guidelines from American Thyroid Association, it says that if the TSH is crossing 10, you clearly require therapy. So this is 11.25, you treat.
Right.
If it is less than 4, you don't require treatment. If it is between 4 and 10, it could be a gray area. There are different caveats of whether one should treat or not. As I said, if it's a pregnant lady, I would treat. If she has other autoimmune disorders, I would treat. If this patient has significant symptoms which suggest hypothyroidism, I would still treat. If the patient has a very strong family history of thyroid disease and has a goiter, I would still treat. Now let's consider a patient who is completely asymptomatic and TSH is 8. Okay, what do you do? If antibodies are very strongly positive, you can tell the patient that your chances of developing overt hypothyroidism in the next 5 years is more than 50%. Do you want to start treatment now or do you want to start treatment later when you become overtly positive? That's all.
But if the treatment is initiated at that point of time, will that by any chance lead to symptoms of hyperthyroidism?
No. It would not matter whether you start treatment now or after 2 years when the TSH has crossed a particular limit. It doesn't matter. So this is a question of counseling. Individually, some people would like to be treated. Some would say, I don't want treatment. So the antibody testing would be for prognostication purposes rather than to decide what to do.
Case number 12, T3 and TSH are normal, T4 is elevated. We have heard him also saying that most probably it is because of high TBG. The TBG may be high because of estrogen therapy, pregnancy or other condition, or maybe the patient is again under therapy. Free T4 in this case was normal, and the history we got later that the patient was a pregnant lady. This is again a similar chart which shows conditions where the TBG is increased or decreased, or in certain drugs may also affect the binding between the TBG and the thyroxine hormone. Case number 13, similar to the first case, T4 is elevated. In this case, we did not get any history of pregnancy. Free T4 was normal. All these things sort of, the patient was not on therapy, so it was a dilemma. We thought probably it can be FDH or because of say dysalbuminemic, that is the binding between the abnormal or mutated albumin and the thyroxine hormone is affected, as a result of which the total hormones are on a higher side. In such cases, protein electrophoresis can be performed, and then we get biclonal bands because there are two different mutants of albumin which are present in the serum sample. We did have a similar case. So this chart shows that familial dysalbuminemic hyperthyroxemia, where there is mutation in albumin, it is an autosomal dominant condition. There is increased total T4, normal free T4, and rarely even the T3 is increased because some percentage of T3 or triiodothyronine also is bound to transthyretin. Again, TBG, transthyretin and other things also may lead to similar findings. Case number 14, T3, TSH are normal and T4 is marginally on a lower side. Again, with some cold chain abnormalities or sample reaching late, certain pre-analytical factors also, we find that certain findings like this may happen. So we thought of all these possibilities. The patient gave an history that the patient has been on phenytoin for seizures for a long time. So probably it was a case of low TBG and low T4 associated with it. In this case, all the three are elevated here now, the T3, T4 as well as the TSH. So probably it is the TSH producing tumor, and so we suggested clinical and radiological correlation.
This could be thyroid hormone resistance.
Okay.
Would look like this.
Right, right. Again, it is, the report is similar, but the TSH value is not as high as the earlier case. Here we thought of selective thyroid hormone resistance, selective pituitary. The thyroid hormone resistance can be selective peripheral or selective pituitary, and the generalized one, that is pituitary as well as peripheral, and there is a mutation in the beta receptor of thyroid hormone. And this last is just a question that in treated cases, say thyroidectomy has been performed or radionuclear ablation has been done for thyroid conditions, how do we manage, replace and follow such patients?
We hardly get history, and patients do not tell us anything. They tell us, you give your report. We have paid for it and we want your report. Then thereafter they will come with two different reports. And then they will come that I usually go to A lab and I have come today to you because you are supposed to be the best. And I think my A lab report is correct. So this is the situation, because we don't know that he is already having, he has his thyroidectomy is done. In fact, this is the usual dilemma.
So the question is, how would you manage these patients?
And
How would you interpret those results?
How are the tests performed? How frequently they are required? What is the
As far as the
clinical
CA thyroid is concerned, some patients of CA thyroid, those with differentiated thyroid cancer, particularly papillary cancer and follicular, their TSH is supposed to be kept on a lower side, just below 0.1, because some of them are TSH responsive cancers. So if you keep the TSH low, they are better off. Therefore, their thyroxine replacement is always a little more than what you would do for a hypothyroid patient. So you would always find slightly high T4 and always low TSH in these patients. That is being done deliberately by persons who know how to treat.
Right.
That's number one. Intermittently, they may be evaluated for residual disease. At that time, they are taken off their thyroxine, and in another 3 to 4 weeks, we see if they have become hypothyroid. If they have become hypothyroid, that is TSH has gone high, you should check their thyroglobulin and antithyroglobulin antibody, because a persistently high thyroglobulin indicates residual disease, particularly so when the TSH is elevated. And then you consider radioablation or whatever. So that's the follow-up for CA thyroid. For Graves' disease after radionuclear ablation, sometimes we give them antithyroid drugs for a few weeks after the radioablation is done, because radioablation, those TT cases as I showed you, thyroid in transition. So initially they have very high T3, T4 and low TSH. Then the T3, T4 comes down, but TSH still remains low. Then T3, T4 also goes low, TSH still remains low. And then finally, TSH will become elevated. So if you see them somewhere in between, it's very confusing, because you see low T3, T4, low TSH, unless you know that this patient has had ablation done, it is impossible to interpret that value.
Right.
It looks exactly like a central hypothyroidism for all you know. So as I said, I
But
can
then
understand your
replacement
problem.
but the replacement will happen once the values fall down.
Yes.
Till then it will be just
Yes.
followed.
Yes, yes, absolutely.
Thank you, sir. So this takes us to the end of thyroid discussions. I hope you enjoyed this session. Thank you.